So in just a moment here, I want to introduce our team, and then I want to show you the final results from the case this morning. So we're going to send you over in just a moment, not quite yet, but be ready over there, Gaurav Rana. So first of all, let me get this catheter up. I want to introduce our team, who has done a tremendous job. Since we met you last, there's another STEMI. So I'm in a different lab. I'm playing a away game, if you will, but that's okay. We're going to make do. I have a wonderful, wonderful team who's put up with me through the STEMIs and through the back and forth rooms. To my right, Oksana Leeper, a Ukrainian traveler. We're going to keep her here. We love her, and so she's going to be keeping me in line. The hardest job anywhere. Allie Gray, Michelle, our nursing talents. Sydney Ward in the back. Gretchen Minton, and many others who have really contributed, including my partner, Gaurav Rana, who has helped a lot with the STEMIs, the vascular, and some of the images that we'll show. All right, next. Next. So it's a very active Tennessee outdoorsman. Severe three-vessel disease, actually treated in an outside community. They tried to cross the CTO, could not. He's being treated medically. He has the risk factors that you can see there. He has absolutely severe claudication, initially right greater than left, and he had, when they did the cath outside, he had absolutely dense right common femoral artery calcium, which I'll show you in just a moment. He had been referred for that, and he was maximized on medical therapy, walking program, and still had severe symptoms. So we fixed his symptomatic first. After that, his left side is worse, and he had an injury to his left foot that's now healing with wound care, but it was a little slow to heal. Okay, next. This just gives you a little idea of the degree of calcium on the axial images and on the coronal images. Next slide. Here's what we treated before, and I think everybody realized that that's a pretty bad right common femoral artery, heavy calcium. The profunda is essentially filling very, very late there, and you can see the runoff. Next slide. So without boring you, I won't tip you off to what we did there, but we were able to fix that and ultimately did DCB at the end, and he had complete resolution. It's not absolutely perfect, but remember, severe three-vessel disease, multiple other issues as well, and that healed up well. His right leg did very well. Next slide. Okay, now we're going to fix his now symptomatic left leg. So let me go back to our images, what we've done so far. So we do vascular ultrasound assisted access, and it actually looked a lot better, both ultrasound and angiographically. The aorta iliac is not too bad. A little ectatic. Good flow down the right leg, and then you see a similar scenario in the left common femoral artery. I think you can see that. And unfortunately, on my away game, our injector was broke, so they had to put through, we'll take a couple of just subtracted images. Let me just say that the SFA is very big. You can see it there. The SFA is not the problem. There's a densely calcified common femoral artery. And then on the runoff, you can see his anterior tibial artery functionally occludes here. And his main runoff vessel is the posterior tibial artery, which has got that disease there, sorry. And final picture of the foot, most of that comes from the posterior tibial artery, and that was the territory where his wound was. So our plan then today, we actually were going to, until it got worse, Sahil Parikh was on the first panel. This was going to be a life BTK because it allows you to fix the inflow, and as long as you do that successfully, give you the option of a drug-eluting bioabsorbable scaffold in a tibial vessel like this. But we chose to go ahead and proceed today because of many, many factors. So it will not be in the life BTK trial. But let me stop for a moment. We've got, you see very severe claudication, ABIs which were low and dropped significantly with exercise, monophasic signals in the SFA and profunda below that common femoral artery, and then a wound when he got injured that's now healing, but it is getting better now. So any thoughts from the panel? Do we treat them both? What order, what therapy, and what are you thinking?
I think that's a great presentation, Chris, and great result on that previous case where you really showed us a great demonstration of retrograde access plus cart and reverse cart. Maybe we can go down the panel here and talk, what would be your approach to this case, Alfio?
2540, Sublime.
Yeah.
Given that we have a claudicant, we have a wound, we've got common femoral disease.
Very good question. I heard about the triple vessel disease and all that. I don't know if that's a threshold for me to do something endo for him or not, because femoral endorectomy you could do on the local. Maybe I'm biased because I'm surgical, so I would do the endorectomy, and I would wait for the tibia, see what happens down in the foot. And if the wound heals with the femoral, I wouldn't do anything. If not, then I would come back and endo go toward that runoff.
And we had a similar case like this yesterday where we were looking at really, really heavy disease, coral reef type calcification in the common femoral artery. Art, what are your thoughts here? Should we just fix we've got monophasic signals in the SFA and the pop. Clearly, that's a significant lesion in that common femoral artery. Shouldn't we just clean that out surgically and be done? Or would you do something endo?
Yeah, I think I agree with this gentleman here. Common femoral is still a place I stop a lot of times and at least get a consult, talk to the patient. I think with the 3-vessel disease, obviously, would lean more towards doing endovascularly. And this guy, he had a good result in the right leg. He's not going to go to surgery. He's going to say, do the same thing to me on the left. So realistically, probably endovascular left, whatever it was, shockwave, DCB, CSI, something. And then I missed where the wound was, but I probably would just do the same thing, see how the wound progresses and not do more unless I had to.
Fadi, what are your thoughts here? I mean, we've obviously got shockwave, we have DCB, we have the combo of other types of atherectomy, superstem placements. There's some decent data at this point. If you were going to treat this endovascularly, would you treat the common femoral artery and then stop at that point, or would you tackle those tibial?
I don't know. I might be in the minority here, but if this was in my lab, I agree with the previous comments. If there's a reason not to do the common femoral artery surgically, then we would consider an endovascular approach. But I might be in the minority, but I would definitely pursue the tibial flow. I mean, all the data. I mean, just Dr. Razavi just spoke about. You need inline blood flow to these wounds. So this patient will need something even after you treat the common femoral artery. It's just a matter of the percentage and the time that you're willing to wait for it. But something that might be maybe a little bit unusual here, that since you have a patient on the table, if you have a multidisciplinary team, is considering treating the outflow and then talk to your surgical colleague, because even if you do an endorectomy, you're not going to access that right away to do an endovascular approach to treating the PT. So that's something that we've done in the past. We talked to our surgical colleague and treated the outflow and then sent the patient for endorectomy. It's not ideal, but it would work in the patient's favor. So
would you do TAMI here, Fadi? Would you just go retrograde access only and just fix it that way?
TAMI here might not be ideal, because you're gonna need like some sort of pedal loop reconstruction or inline blood flow to the distribution of the wound itself. So the Safari registry and the Angiosome papers for endovascular therapy, at least, and I agree, endovascular therapy at least, you would want to work within the foot itself, just because there's a wound there.
What the hell?
So TAMI might not be ideal because of the location of the disease. It seems to be like distal and plantar.
How about Dr. Babaev? Would anybody else do something differently here?
Yeah, I would treat both lesions at the same time, given the fact that it looks like it's critical ischemia. I think you can treat both of them safely, and I would do some sort of atherectomy followed by drug-coated balloon for common femoral, and would address the PT lesion as well. I think you can at least achieve. Work on the common femoral. I know it's a hard lesion to deal with, but you can definitely can treat it and get rid of the hemodynamically significant stenosis, and later on, if whatever is needed, patient can go back and
what's the length of it, and we'll hook into that one.
Surgery done as needed, but I would treat both at the same time.
3-0.
Peter, Eric, any thoughts on how you would treat this CFA lesion? I mean, we've got some options. What type of atherectomy would you do if we were going to do an endovascular?
3-0-40 shockwave. 3-0-40 shockwave.
To just answer the first question with a part of the answer to the second question.
No, I don't.
I would absolutely tackle both at the same time. You have a critically ill patient. You had a non-STEMI recently. He's going to have a hard time healing. The last thing you want to do is superimpose an infection at the foot on top of everything else this guy is already dealing with. So I think you need to be appropriately aggressive in the situation. The way that I would tackle this, especially with the 7060.
So
I think you need to go after
with that one already.
Back. I would take a 2-0.
No, okay. So we could hook up to either one. All right, let's take the 2540.
There. I think you need to use distal protection here.
What's the shaft
and
length?
Then after you fix that common fem, I would then go back after that PT. It looks probably to be at least a 2 to 2.5 vessel all the way down. You could probably get away with a 1.25 solid.
Just give me a 2.540 for right now.
I don't think you need to do a lot of pedal loop reconstruction here.
Is it?
In my view of the distal foot film, it looked like once you got to the ankle, everything really opened up. It's just there's several skipped calcific lesions along
Is this
the way.
a rapid exchange over the wire?
Eric, any thoughts? Anything different?
You got wire? Real tight?
So
Real tight?
I would agree with
wire?
Dr. Carocchio
I
for
can't
the
hear you.
first part.
Tell me
and,
when.
You know, a bias being surgical, I think you could, common femoral endarterectomy definitely can be done under local, but I would also treat the tibial vessel at the same time with a, antegrade approach through that patch and spin it with orbital atherectomy and then, tackle that. I think you need to get this guy or this woman flow all the way down to the foot.
Yeah, I think this is a good case of the problem. We've got almost an inflow lesion, right, situation. It's technically the common femoral artery, but it's an inflow lesion in terms of the monophasic signals below it. We clearly have an outflow problem, and like Fadi was saying, we have to make sure that pedal loop, if it's not intact, that we have really robust flow to at least the wound to heal it at this point. I think it really depends on local expertise in terms of how we're going to tackle that common femoral artery lesion. I think a discussion with your surgeon is not a bad idea. I think it's, let's face it, the gold standard is still endarterectomy in good hands. And like Dr. Carocchio said, he can fix this under local, somebody that's had, a prior STEMI and has bad cardiac reserve or cardiac disease. Chris, we have kind of multiple opinions here. I think you heard this.
I've been listening here, and I've got dizzy, so I almost stopped listening. But I will say, let me just say this: there were 29 different opinions from 15 from just only 7 panelists. That's pretty amazing.
Right. That's
but
right.
I agree. Listen, I agree with the
It's
comments made. And let me just say a couple things, please.
Yes.
We have 5 vascular surgeons in our group, and I get along with them. Okay, no. I need to. So I want you to slowly back it up. Keep that wire in the foot until we see the balloon or common femoral. So we did discuss it with him. And listen, I just did a debate in Viva last week with Jason Lee. It was actually a lot of fun. Common femoral endarterectomy. Is it still the gold standard? And look, it's a great treatment in the right hands. I think the wound infection is more than people, always. Just take it out. All right, we'll just take the shockwave. You're out of wire. Okay. So I think that in the NISQIP, it was 8%, even experienced hands at 30 days, and the mortality was 3.4%. Now, it is for a very calcified lesion, it is still good. I do think we have new technology. Let's take the 7x60 shockwave. We're going to do the 7x60 shockwave first. Okay, and then we'll shockwave downstream if we need to, and then we'll put a drug-eluting stent if we need to. Okay, so anyhow, I think all good comments. We did discuss it with our vascular surgeons. I promise we discussed it with a patient. And so the idea is, I think we can do this endo. If we do this correctly, we will not burn any bridges. And I do think we have technology now that allows us to at least consider this. Pretty soon, Shockwave will have an 8mm balloon, which will even be better. And as everybody knows, the drug-coated balloons go to 8, 9, and 10. So we have more of a drug-coated balloon that really matches the size of the vessel. I think below the knee, drug-eluting scaffolds work extremely well. And I think we'll be able to get inline flow. And now finally, we have the 7x60 shockwave, right? And finally, we do have larger separators that just came out within the last few weeks, 7.5, which makes it a lot more reasonable to put it. If you have to stent, I would never put a nitinol stent in the common femoral artery. It would always be an interwoven so that there's no fracture, so that it bends with the patient when he bends or she bends, and that it stands up to the calcium. So our plan on this, having intertwined the 29 opinions into what we're going to try to do, we're going to shockwave with a 7x60 in the common femoral artery. We'll probably take a shockwave 2.5 or 4 or 3.0 in the distal PT, see how we look. We'll then probably drug-eluting stent if we need to the posterior tibial artery, and then DCB with a big DCB and the common femoral artery, and then provisional Sapera stent, if that sounds okay.
That sounds like a great plan. We have go ahead, Alfio.
Yeah, just one comment. The Metzger's comment was an interesting one. He said if it's done correctly, and he's right. I mean, talented person, straightforward. That you have a wire in there, you treat the tibial, goes great. I'm going to just propose the flip side of that. What's the downside of doing the femoral and waiting for the tibial? Because you have triple vessel disease. Everything you said you wouldn't operate on this guy for. If something happens downstream and you run into trouble, now you have a guy with triple vessel disease and a cold foot. Is that something you want versus just waiting and see if the common femoral solves the problem? Because traditionally, even if you don't have direct line to the foot is correct. That's the best option. But often you have perineals.
Chris?
And 2/3 of the time, having straight line flow to perineal will heal your wound. So what's the downside of the opposite?
So what do you think, Chris, in terms of, we talk about this with CLI all the time, staging procedures. What are your thoughts on staging this case? And obviously, you know this patient well, So.
I do. And so I think all good thoughts. I think that, again, first of all, please, the last thing I would want with this demonstration to be advertised as a cowboy demonstration. And I would also say that if you're not an experienced operator, you shouldn't touch a common femoral artery with endo. And if you don't have a great relationship with your vascular surgeons, you shouldn't touch one endo. All right, now back to your question. You got nice and straight, please. Okay, you got wires as tight as you can. Tell me when you can. All right, so all those, you ready? Okay. All those things said, I really think that if we've got a wire through and through there and a drug-eluting scaffold to the posterior tibial artery, I think the chances of a meaningful bad thing are pretty bad. Now, we can fix a lot of the cold feet here. You're right, boy, I wouldn't want to have our surgeons on a Saturday have to say, we got to fix a cold leg. But I think the number of times, if you do this correctly, that happens is pretty low. Go forward. Okay, stop. Now, what we're going to do now, let's do a roadmap, please. All right, what we're going to do now is find out where that common femoral artery is with a roadmap. You ready? I'll tell you when to inject. Inject.
So I think this is a great demonstration and really discussion of what we talked about yesterday when it came to, common femoral disease and how oftentimes it extends into the origin of the profunda and proximal SFA in these patients. And, we have some good endotherapies now. We don't have good long-term data, but in the short term, the data is looking very compelling.
One.
Chris, and you treated the right common femoral on this patient already, so you probably have a hint as to how it responded to therapy, right?
That's a great point. And by the way, in this one, the other thing that's important, folks, is that you can see some on the roadmap, but remember we IVUS this as well. Go to 4. There was no disease into the origin of the profunda or the origin of the SFA, and it's a pretty big vessel. But you're right, we're 4 months out from the right common femoral artery with a normal ABI when we did these ABIs. It was 0.91 or something like that. So it was a durable result and, looks really good. Let's see, 30 seconds, come on down.
Now, one thing we've seen, Chris, in tackling these lesions with shockwave is that on ultrasound, because a lot of times we would get follow-up ultrasounds on these patients, the ultrasound still looked pretty ugly, even though the flow was significantly improved, the patient's symptoms were improved. Has that been your experience as well?
That's a good question. We've done a whole bunch of them, quite honestly, and you're right, they're not all perfect, and it doesn't magically make the calcium completely disappear. Okay, 4. But what we've seen is that, first of all, a couple things during the procedure. There's almost no distal embolization. If I was using atherectomy here, we'd have a filter all day. The other thing is the patency and the ABIs and the symptoms, which are most important to us, tend to be excellent. Okay, but you're right. And we've had a mixed bag. Some that are just amazing 3 or 4 years later, they are very good. We're actually 3 years out from our common, but some are not so good. Come on down. So no, it's a good point, and I think you need to add something to it. In other words, just a 7.0 and this is not going to be big enough, and we want some anti-proliferative therapy. Okay, go up. And I'm just changing the emitter position a little bit. And so what we're going to do is, in just a moment, folks, we're going to see about the other shockwave for below the knee. We did a balloon downstream already while the panel was opining with a 2.5, just a regular balloon. But on our IVUS there was some calcium, so I think CSI or something was brought up, and or if we already have shockwave and we're paying for it and open it, we'll probably just use a shockwave peripheral one as well. Okay, 6.
Sounds great.
Let's go to our fluoro, please. Make sure they're seeing. Okay, there we go. So when we left, we did this Shockwave 7 balloon. You can see it expanded very well. All right. So after that, I want to show you the angiogram. And really opened up nicely. Of course, there's some calcium that didn't clear out. This is a bigger than a 7.0 vessel, but no dissection of significance, grade A maybe, and beautiful flow in the profunda. All right, so then we went down, and this is that tibial vessel. This is a 3040 Shockwave guided by intravascular ultrasound. And you can see it expands pretty nicely, okay? We really had already had a drug-eluting stent ready. Now, but let's take a look at that afterwards. This is the posterior tibial artery distally afterwards. And I don't know about you guys, but I'm kind of happy with that. I think the flow in that looks pretty good. I'm going to let it play again. And with the lithotripsy angioplasty, I don't see any evidence of a dissection angiographically. Would everybody agree with that?
I think so.
Agreed.
Yep. Panel agrees. Yep.
Okay, good. Now I'm going to go to the next picture. So now this is a Medtronic 8x40 drug-coated balloon. Okay. And this is it. It expands nicely. And we went to about 12 atmospheres for 4 minutes. Okay. Here's a DCB, nice expansion. And here's a picture afterwards. Okay. I think it's looking pretty good. Again, I get it. There's a little bit on the lateral wall, but the flow is normal. All right. Now, several minutes later, so now we IVUS. Now I want to show the before IVUS, please. Can we let them get the IVUS up. Okay. This isn't even its worst part, but it gives you an idea. There's heavy, chunky calcium everywhere. All right. Now show the IVUS after we just did this. You can see the IVUS. Okay. Now go ahead and play it, please. This, folks, is the post. There's a little calcium. That's what we're seeing on the lateral wall. But I would say we're widely patent without any significant dissection. Okay. And then let's take a look. Go back to fluoro, please. All right. So there's the IVUS we just showed you. And here's the pictures distally. They're, just making sure there's no recoil, sorry. And then here's the foot. You got a wire all the way down the foot, and the other vessels coming in, no distal embolization, and good flow. The wound was down there in the plantar part of the heel. I think we're going to be okay there. So let me just stop for a moment and see, we had other options ready. We had a 7.5/30 Sapera interwoven stent for the common femoral artery, or a 3.0 or a 3.25 drug-eluting stent for the distal posterior tibial artery. But given some of the very astute comments, especially from our surgical colleagues at the beginning, I think right now we've done what we've set out to do. Let me get opinions from the panel. Should I do anything else? Would you anybody put a drug-eluting scaffold distally in the posterior tibial artery, or a interwoven scaffold in the common femoral artery, or go to a 9.0 DCB in the common femoral artery, or would we declare it a victory on not my own lab, and playing on an away game? What do you think?
Let's start with Eric at the end, and maybe we could add another question. Would anybody touch that distal PT common plantar artery at this point? It's a little bit narrowed, but again, we were willing to stop after the common femoral artery. So do we really need to touch it? So 2 questions. What do you think, Eric?
Yeah, fantastic result. Congratulations. I think you're definitely done. Nothing else to treat here. Just to take a step back and ask you, did you have any trepidation accessing the right common femoral after you treated that with a lithotripsy before? And then question number 2, did you or when do you consider placing a wire in the profunda to protect yourself when you're ballooning across the bifurcation there?
Yeah. Okay, great questions. First of all, as I said, it had been 4 months, and we already had a duplex with an ABI of 0.92, and I looked at the duplex of his right common femoral artery, so it was okay. So 4 months later, I feel completely okay with accessing it. With that degree of calcium, I'm not going to use a closure device. One of these nice folks will be the closure device, and they're very good at it. All right. Number 2, about the profunda. The profunda is huge there. I have no trouble wiring. Yeah, I don't think we're going to need to protect it with a wire in this scenario. Now, if it was super, super tight, calcified in both of them, absolutely, I would wire both of them. And I would also, the nice thing about the Shockwave is you can double wire it. and still leave your wire in the profunda while you work. And there have been times where we shockwave the profunda and the common femoral into the SFA, obviously after careful vascular team consideration. So here I didn't think we need to big profunda. The disease actually ended just before the bifurcation. I felt very confident we could wire it again. Accessing 4 months later with good vascular ultrasound here and an ultrasound before we came in and relief of symptoms in a 4-month procedure. I was okay with it.
Peter?
So I live and die by the phrase, the enemy of good is better. Guys, Chris, your whole lab, the dishes are done. It's time to go to bed. Leave this alone. Walk away like a champion. It's fantastic.
I think I hear nodding back here. They're saying we're done, and I'm hearing now. As soon as I say that, they're they've had 2 STEMIs, 2 live cases, and then I've got another one to do. So if you hear any nodding and shaking and rattling, yeah, everybody's in agreement. But I'll listen to the rest of the panel.
Congratulations, Chris. Great work. Beautiful job. I think you're done and deserve a good rest. Hopefully, they're not going to call you for another STEMI.
Fadi, what do you think? What do you think, Fadi?
It looks great, Chris. I would actually, say that I would avoid stenting in that distal PT and around the ankle. I mean, we've seen disasters happen. It looks nice like the first couple of days, and then you have to deal with the consequences. So this looks great, Chris.
Yeah.
Thanks, Fadi.
Just one quick question, Chris. What are you going to put this patient on now? Oral medication therapy.
Well, that's a great question. And we could throw that back, and we've got a couple minutes left, but for sure he'll be on dual antiplatelet therapy. Now, he doesn't have an absolute need for other anticoagulation. In other words, he's not an AFib. He doesn't have an artificial valve or anything like that. So he'll get dual antiplatelet therapy. He was on cilastazol already. If we think we fix this, we may stop that, and I would consider putting him on the rivaroxaban 2.5 BID. But then we have to balance cost, 80 years of age, and all the other issues. What do other folks say? Do you feel mandated by some of the data, Voyager, Compass, and others to put them on the 2.5 BID? And if so, you drop the aspirin?
Yeah, maybe we'll ask Art and Alfio here. Yesterday we had a great talk by Dr. Olin, and he showed us that, some of the data showing chronic thrombus is really kind of the inciting event in tibial runoff. So what do you guys think, Art? DAPT, Compass, Voyager, modified? What are your thoughts?
I like the Compass Voyager data myself. I use a lot of it, but you have to take into account the 80 years old. I think the bleeding rate. He looks like a very robust guy, so I think his bleeding risk is going to be probably lower than the average 80-year-old. But when they get over 75, if you look at some of the Compass sub studies, I mean that definitely increases your bleeding risk, which erases the benefit. But I do like it. They have high, what you're really preventing is acute limb ischemia, limb out events. So if he's a low-risk bleeder, I definitely would consider it. I would take the cilastazol off and just use the baby aspirin.
Likewise, we've transitioned whenever possible to the 2.5 and aspirin.
I think everybody's going Compass Voyager in this case. Chris, we'll interested to see what your thoughts are. Great result, spectacular case. I think it shows your expertise on how quickly you fixed all these different levels of disease, and this is very common as we see in CLI patients.
Thank you.
Well, Thank you. Definitely.
I appreciate the